So we're going to start some special topics for the reproductive system, starting with just a very brief mention of the human sexual response. This was already in the slides before I got to it, and I'm really, really happy about that because there were some really, really historically significant sexual health pioneers. Masters and Johnson were some of them. They're the ones who came up with the human sexual response cycle, but then they're actually predated by a decade or two by a guy named Alfred Kinsey, who did some really, really important work in human sexuality. Prior to these publications, we really didn't even know the basics, at least in medical science. There were a lot of things that people had intuited, maybe some traditional health practices and from other cultures that are being completely ignored by the Western world. And so it really took Kinsey and Masters and Johnson to start doing official research in this before doctors had really any training in human sexuality. So imagine having some problem related to sexual health in the 1940s and just not being able to get answers about anything because medical doctors weren't trained in it. It's from a very puritanical history that we have in the United States. So I'm just really happy that this was here in the first place. I went and I got one of the original charts for Masters and Johnson about the human sexual response. So basically, they discovered by experimenting, by watching and taking notes on people who are actually masturbating or having sex with each other about what they experienced. And they discovered that there was going to be the initiation of a desire, an increasing peak towards arousal, either a plateau or orgasm. Few people can experience multiple orgasms. And then that leads to resolution. And of course, arousal is going to coincide with engorging erectile bodies, both in the penis and the clitoris. And of course, the clitoris hadn't been discovered back then. Not in its full form. We knew about the glands of the clitoris, but we didn't know the full extent of the clitoris back then. But we knew that things got engorged. We do have some, ways of assessing whether orgasm has happened in males and females, and it's distinct for each of them. It seems more or less everybody experiences the same cyclical response. And of course, that's independent of the concept of fertilization. Fertilization is on this slide for some reason. If a lot of things coincide, if the ejaculate is on the vulva or in the vagina, if there's enough sperm, if they manage to travel to the lateral uterine tube shortly after ovulation, then fertilization can occur. Sperm can meet egg and fertilization can occur. Now, this is the slide that made me go and update this whole lecture. This was the original slide. That was just this. And there's some problems with it, some really, really serious problems. One of the problems is pretty simple. There's a difference between perfect use and common use of various contraceptive methods. So what I mean by that is condoms, for example, with typical use, they're not super effective. Do we have, what did they say? About 10 pregnancies out of 100. That number is really, really varied depending on which study did this research. If you're using condoms correctly, the failure rate would only be about 1 to 2 per 100 people, 100 women. So there's a big difference between common usage and correct usage. And for a condom, that means that the penis should be fully erect when it's put on. You need to pinch the tip. You can't put it on and then realize you put it on the wrong way and then flip. There can be some semen on the tip when you just put that on the side that's going into the vagina. If you're supposed to withdraw immediately after coitus and remove the condom completely and then, don't reinsert it after that. You need to use it every time. So there's a lot of ways that people mess up condoms and condom usage that leads to that 10% failure rate. On the other hand, something like an IUD, a failure rate of less than 5%, yeah, less than 5%, less than 1%. Those are 99.99% effective. that infuriated me. And there's a reason, and it's a really weird reason, why if you go to older sources, information about IUDs is going to be really weird. And that's what's going on in this corner. So I know the slide is a mess. I'm sorry. So this is going to give you some it's just additions to what's over here. Or in this case of IUDs, a correction. That's a correction. This is just incorrect. Now, there's an older generation that hates IUDs. And there's a really good reason for that. It's not good enough reason for them to put incorrect information into textbooks, but they do, or they did, as you can see here. This is an evil IUD from the 1970s. This is known as the Dalkin shield. Now, the modern day IUD is shaped kind of like a T, and it's got these like flexible arms, so you can insert it sort of in a straight line and pull it out, and the arms will go like this, and nobody's uterus has to get hurt in the process. But IUDs didn't always look like that. Historically, IUDs have had a number of different shapes. IUDs are an absolutely ancient form of contraception. People used to put stones into the uterus of camels, of female camels, if they were going to use them to cross the desert, because a pregnant camel is going to need more nutrition and water than a not pregnant camel. So that was the earliest form of IUD, is sticking small stones into the uterus of a camel that's about to cross the desert. So that's absolutely ancient, which I know, it's weird. So they've had a lot of different shapes over the years. This is just one of them. If you have a uterus, you probably can see one of the problems with it right away. I don't want that in my uterus. That's just a personal thing. Oddly enough, the shape of it was not the main problem. And I've gone on a little rant in the notes here, so that's why I'm showing you the notes. The main problem with the Dalkin shield was the string. The string was not a biocompatible thing. It's essentially a string. And that string was harboring a lot of bacteria in all of the women who got this IUD, and it was causing a lot of infections. Some women became permanently infertile, and there was a high rate of uterine, I just lost the word, perforation. There we go. Really, really high rate of uterine perforation, which intuitively to me makes a lot of sense because this closely resembles a buzzsaw. But again, it actually had more to do with the recurring infections than the actual shape of the IUD, which is wild, but that's what it is. So an entire generation thought, you know what, IUDs are the worst thing in the world. Why did we even think of this? And it was only really in the United States, as far as I know. I would have to check my history on that. But a lot of European nations, Asian countries, did not legalize this IUD. They did not have the Dalkin shield. And in those countries, IUDs are a lot more common than they are in the United States because nobody had this absolutely horrific thing put into their body in those countries. So in the United States, medical establishment said, nope, IUDs for nobody. It's still to this day something that you can see in healthcare is people saying, no, IUDs are bad, they're terrible. But it's not accurate for modern IUDs. So there's some really, really good IUDs out there. Mirena is one of them, Paragard. There's another one that's come out in the last few years that I'm not familiar with. There's hormonal, there's non-hormonal, and they're incredibly effective. And part of the reason they're incredibly effective is that they have nothing to do with human intervention. You don't need to do anything for them to work. So I've already mentioned, like, using a condom correctly is much more effective than using a condom incorrectly. But there's no such thing as using an IUD incorrectly. Really, the only way you fail with an IUD is if there is uterine perforation, or if you lost the IUD, which can happen in like the first couple of weeks of implantation. When you've had it inserted, it is possible to cough it out or have a strong bowel movement and lose it without recognizing it. It's rare for uterine perforation to occur these days, but it can happen. So if your IUD is swimming around in your peritoneum and it's not in your uterus, then it's probably not as effective. That's really the only way it's going to fail, is if it's literally not in your uterus anymore. So and again, those are really, really rare events. So yeah, IUDs are incredibly effective. I've heard all kinds of things from students. Some of it's just what's it called? I'm not doing great with words today. Just rumors about, oh yeah, my buddy said that, her baby was born just holding on to the IUD. Sure, if you say so. But if I get the real story from people who maybe have had pregnancies while having an IUD, it's because the IUD was no longer there. So yeah, IUDs are awesome. Highly. It's actually, statistically, this is the form of birth control that the fewest people feel the need to change. And it's also the most people in healthcare choose IUD statistically over any other form of birth control. Now, the IUD does not protect against STIs. This is strictly about conception and birth control. This has nothing to do with STI prevention. The great thing about condoms, again, when they're used correctly, they are incredibly effective and they prevent STIs. Sexually transmitted infections is the modern way to refer to that. We don't really say STDs as much anymore. So yeah, this was just bad enough that I had to go and get some better resources. All of these numbers are strictly from your textbook, including the family planning. Natural family planning is a 9 here versus withdrawal method and rhythm method 20 to 30. So what I mean, withdrawal, that was accurate. But rhythm method means you have an idea of when you are ovulating and you avoid unprotected sex during that ovulatory period. And just before. So you understand the timing. Now, if you're very, very educated and you really understand the menstrual cycle and your own body, and you as a couple are working towards this as a team, and you actually manage to avoid intercourse during any sort of fertile period, then you get that 9% failure rate. Then you get 91% efficacy. But remember a few slides ago when I was explaining how many holes you have? People need that. So maybe you personally didn't need that, but somebody just had their mind blown, and that's okay, because the state of K-12 sex ed in our country is really, really terrible. People don't know these things. They don't know how many holes they have. If they don't know how many holes they have, I can't trust them to understand natural family planning enough to actually execute it properly. So ask anybody who's ever worked in any sort of clinic that deals with underage pregnancy, and you'll see that generally people cannot be trusted to be knowledgeable. That's also why I put this in BIO127, and I'm not waiting for BIO212 to talk about this, because you really shouldn't be at a 200-level college course before you get this information. It's a really, really, really important information. Okie dokie. Okay, kind of talked about all of that. The morning after pills, I think in your textbook it says it's something around 70% effective. It's just very, very high levels of some of the hormones in birth control pills, so if you were about to ovulate, it will stop it. If you already ovulated and there's an egg ready to be fertilized, then it's not going to work. So let's say you're not on any form of birth control, or you are on birth control but you didn't use it correctly. Oh, and that works for birth control pills as well. I don't think I addressed pills. I think their oral contraceptives numbers were fine, so I didn't feel the need to change that. Pills can be used incorrectly as well. You need to take them at the same time every day, and several medications can interrupt their efficacy, including, but not limited to, certain forms of antibiotic. So if you get an infection and you're on antibiotics, please do ask your doctor if it will interfere with your birth control pill. And you can tell that this is old. The future of birth control, male birth control pills are coming down the pipeline. It'd be great if they were. There actually was a male birth control pill that went into clinical studies, but men were complaining that their arms hurt. I think that was an injection, and they're like, my arm hurts, and they stopped the study. Now, that's fine. Stop the study if people are in pain. I agree with that. The thing is, when female birth control pills went on the market, a lot of women died of the stroke because the progesterone and estrogen levels were too high. If you have really, really high estrogen, it can also cause blood clotting. So a lot of women died of the stroke after we put like approved birth controls and had them on the market. A lot of women were dying, and we didn't pull them from the market. But now, these days, men go on, to clinical trials, and my arm hurts, and it gets pulled. So I'm not saying it's bad that we are treating men well. I'm saying that it's bad that we treated women poorly. Let's see. So fertilization, that acrosome contains digestive enzymes that will help break through this outermost jelly coat right here and into the vitelline membrane. The nucleus of the sperm is going to fuse with the nucleus of the egg, and then this is a fertilized egg. Now, fertilization is a distinct event. It just means sperm met egg. It does not mean pregnancy. And ideally, fertilization happens out here. Put me over here. We want fertilization to occur out in the lateral portion of the uterine tube. The reason for that is this blue layer right here. We need a very, very specific layer to develop in order to implant into the endometrium. If this layer has not developed, there can be no implantation. So let's say this egg made it all the way out to the body of the uterus before it met the sperm. Fertilization could occur, but not enough development to develop what's known as the trophoblast layer. If that trophoblast layer doesn't exist, it cannot implant, and we might hit the menstrual cycle before enough development occurs for implantation. And even if it does have time, it might implant a little bit low, and implanting low can actually be dangerous because we can start embedding into the myometrium, and that's going to cause a lot of bleeding during childbirth. So this is the ideal place for fertilization to occur. So it is really important scientifically that you understand that we do need a specific layer to develop in order to achieve implantation. I'm not saying anything political. I just want you to know when politicians don't know what they're talking about, because they mostly do not. I'm not making an argument one way or the other for, pro-life, pro-choice. I'm just teaching you the science of it. We probably do menstruate fertilized eggs every once in a while, especially if somebody is not on some form of birth control. That is probably a fairly common event. Okay, so this is occurring over several days. That uterine tube is lined with a ciliated simple columnar epithelium, and that is helping that if fertilized ovum, that potentially fertilized ovum, it's moving it towards the body of the uterus, but that does take several days. Depending on the resource you're looking at, it could be 3 days, 5 days, 7 days. I'd say an average of 5 days to get from here to here as a single cell or as a developing embryo. So we do have several phases here. This is from our old resource. I've got a nice clean one somewhere. I thought I had a nice clean one somewhere. Am I filled with lies? Do I not have a nice clean one? I put it down here in our embryology content. Okay, so fertilization. Then we're going to start having cleavage, which means we're going to increase the number of cells, but we're not increasing by size. At a certain phase, we start calling it a morula. And the term here, the terminology actually means berry. The morula is a berry. I don't know in what language, but that's what it means. And a little bit later, we have enough cells, and we actually develop a sort of fluid-filled space. A fluid-filled space is known as a cyst. So this is the blastocyst phase, and this is day 6. So these cells are actually going to become the embryo proper down here. The rest are going to be some other important things. So again, we've got this super special outer layer. That's going to allow for implantation. That should correlate with what we were doing. What are we doing? Let's find the slide that I was on. I was on this slide, more or less. Yeah, so that's the development that's happening over the first few days. So a lot of that development, again, morula to blastocyst, that occurs before implantation even occurs. Now, one thing I'm going to convey during our embryology lecture, oh, you know what, this might be a good time to start. I'll say this and then I'll stop and then we'll go into embryology lecture. There's a difference between differentiation and growth, and that's going to be the major difference between the embryological period and the fetal period. Differentiation means we take one fertilized egg, one cell. That cell can become any type of cell in the human body, and it's going to divide into every type of cell in the human body. But we're going to start differentiating, and as we differentiate into different cell populations, the remaining cells, the new cells, the divided cells, every time we divide into a new cell, that cell can become fewer and fewer things. We're going to have a certain degree of differentiation where, okay, you could be integument or nervous system. Or at this point, you can only be nervous system. Or at this point, you can only be a neuron. Or at this phase, you can only be any type of glia. At this phase, you can only be a certain type of glia. And so when we differentiate, we get more and more specific. And that's what it is to be a stem cell. Stem cells can be many types of things, and then eventually they differentiate into specific cell populations. So that's differentiation, and that's what happens generally during embryologic development. Whereas once that stem cell has become its cell population, maybe it needs to divide and grow, that's what happens during fetal development. So we'll talk about more embryologic versus fetal development in our next segment.